Good evening, everyone. My name is Rich Riley. I'm a member of University Hospital's Marketing and Communications team, and I'll be the moderator for our virtual health talk this evening. I'd also like to acknowledge my colleague, Kelly Crow, who is assisting in this event as well. On behalf of the entire University Hospitals family, thank you for joining us for this evening's presentation, When Back Pain is Not Just Back Pain. Diagnosis and treatment of sciatica and degenerative lumbar spinal stenosis. Sciatica is one of the most common yet misunderstood types of pain. As many as 40% of people will get it during their life, and it becomes more frequent as you age. Degenerative lumbar spinal stenosis, or DLSS, is a leading cause of pain, disability, and loss of independence in older adults. Couple of housekeeping items before we begin. In this platform, all attendees are muted. While you won't be able to ask questions through your microphone, please note the Q&A function at the bottom of your screen. If you have a question that is not addressed in the presentation, please submit your question through the Q&A feature, and our presenter will address questions at the end of his presentation. Also, this evening's webinar is being recorded and will be available for viewing on demand in the near future. It will be posted on the University Hospital's website, and as an attendee of this evening's session, you'll receive an email after the event that has a link to this evening's presentation. It is now my pleasure to introduce our speaker. Dr. Zachary Gordon grew up in Lyndhurst, Ohio. He attended the Ohio State University for undergraduate school and Case Western Reserve University School of Medicine for med school and his orthopedic residency. Dr. Gordon completed his spine surgery fellowship at UPMC in Pittsburgh. Dr. Gordon currently serves as the co-director of the University Hospital Spine Institute. He is a member of North American Spine Society Education and their website committee. Areas of interest are minimally invasive and lateral spine surgery and adult degenerative deformity surgery. Dr. Gordon has 2 children, and as he likes to say, no free time, and plays golf to keep his sanity. Ladies and gentlemen, I'm very pleased to introduce to you Dr. Zachary Gordon.
Thank you, Rich. Thank you, Kelly. And thank you to everybody who's attending virtually. These are really a lot of fun to do in person. It's really a shame that given the current circumstances that we have to do these remotely. So I'll try to keep it lively, and I look forward to the Q&A at the end of all of this. And I always laugh because I've been with University Hospitals now for 7 years, going on my 8th year now. And we've given this talk, I don't know, maybe about six or eight times over the years. And we always do the same thing about low back pain. And I told Rich, I'm tired of talking about low back pain. So my very first slide says low back pain. We'll talk a little bit about this, but I want to highlight some of the differences between the typical low back pain that people experience and the types of problems that we typically treat surgically. So if you look at some of these big studies, we estimate that over 80%, so 4 out of 5 people get some type of significant back pain episode during their life. So 5% of the population every year will have a new onset of lower back pain. And what we find on autopsies of people over the age of 50 is that 9 in 10 have significant disc degeneration in their lumbar spine or their lower back. And so, really 100% of people experience back pain at some point during their life, and the vast majority will have some type of significant event. Now, most of it resolves within a couple of weeks, which is why the vast majority of these people aren't flooding our emergency rooms and offices with back pain. But we do see some people, and a small number, that will go on for more than a couple of weeks. So we talk about this entity of degenerative disc disease, which is, I put disease in parentheses here because we don't really know, is it a disease or is it really just the way we age? Why do some people hurt and why do others not hurt so bad? But we typically start getting back pain in our 20s and 30s. It's not very common in adolescence. There's usually some type of underlying structural problem. But once we get into our 20s and 30s, when we start wearing out. So I tell my patients all the time, once you stop growing, you really start aging, and that's when the problems start coming on. The symptoms typically decline after the age of 60 to 70, really, because at that point in our life, we are done going through the degenerative process and things have typically stiffened up. So it's as the discs are wearing out that people tend to get back pain. And the reason for this is the discs are the shock absorbers between our bones. They're really meant to compress and flex and move in various directions. They're not meant to really shear back and forth, but they are meant to compress down and kind of twist and rotate a little bit to provide motion of the spine. And as they wear out, all of that force gets transferred to the bones, and that's why people start to have back pain. It's just like the cartilage in your knee or your hip wearing out. The normal cushioning is gone, and so now your bones bear all of that weight. So this is an actual cadaveric specimen of what a normal lumbar spine looks like. And you can see here on the left side of the screen, this is a cut right down the middle, as if you sawed somebody in half from head to toe. And we're looking at the bones of the lumbar spine. It says S1 is the top of the sacrum, and then the structure in between is the disc. And you can see how it's a nice, healthy, yellowish looking cartilage. They're tall. You can imagine they're very fluffy and supportive. And then in the center here, you see these nerve roots we call the CE or cauda equina, these strings hanging down, or the spinal nerves. And then if you move a little bit off the midline towards the side, you start to see the area where the nerves leave in between the two bones. These areas back here are the joints of the spine. And the reason we're giving this talk tonight is as these structures wear out and as the discs start to bulge and the joints start to form arthritic changes, namely bone spurs, you can see how those spinal nerves in the hole. And if the disc bulges backwards or herniates, you could start to get pressure on the nerves in the center of the tube. So for the vast majority of people that get back pain, usually it comes on fairly quickly. It can slowly worsen over time. It can suddenly happen when you bend over to tie your shoes, or even if you have a coughing fit. But typically we see people get worsening pain with prolonged sitting or prolonged standing, just staying in one place. And if you kind of rest it, lay down flat, or start changing positions, it gets better. Now, there are times when people can have radiation of that pain into their butt, their groin, and their thigh, and that's very common, but it doesn't typically go below the knee. And the key here is that we make this diagnosis when people have a normal neurologic exam, meaning there's no weakness or sensory changes in the legs, and when they're able to walk. If abnormal neurologic findings are present, then we start to worry there could be something more going on. But here's the best part. Nearly all low back pain really resolves with adequate treatment, and there's no need for surgery for lower back pain. And I'll give us our shameless plug here that the Spine Institute at University Hospitals really offers a number of comprehensive solutions, and we have a growing army now of medical spine physicians, nurse practitioners, and physicians assistants that work side by side with the surgeons. As well as a large army of physical therapists, pain management, and rehab physicians who provide injection services, chiropractors, and then a whole host of alternative treatments through the Connor Integrative Health Network. So usually when we're seeing people for these problems, just the typical lower back pain that's been there for a few weeks or even a few months without abnormal findings, people do get better, and we have a whole host of physicians and other extenders and supportive care to help people feel better. But what I really wanted to focus on this evening was the red flags. And so there are a number of different things that can happen to the lower back, but I really want to focus on these neurologic conditions here. So things that start to pique our interest as surgeons when people start to develop sciatica. And sciatica really just means pain in the leg. That's all it means. And the pain in the leg is usually coming from pinch nerves in the lower back. So it's not the sciatic nerve that's being compressed, it's the spinal nerves, and that causes pain to travel down the leg. And then if people have abnormal bowel or bladder function or any weakness on their exam, we start to get very worried about that. So just a quick remark on MRI studies. People come to us all the time with several weeks of lower back pain. They have no neurologic symptoms, none of the red flags that were present on the slide before. And they will say, I need an MRI of my back. And we always get into these conversations. Sometimes they can be quite heated, that most people don't need an MRI. And what this slide shows is as we age, if you look at people who have no back pain at all, and we've done these studies, you can run them through MRI scanners. People in their 20s, over half of them will have a bulging disc. And 1 in 5, this black bar here, 21% of people aged 20 to 39 have a lumbar disc herniation and have no symptoms. And that number, by the time you're over the age of 60, rises to about 1 in 3 people have a herniated disc. And then when you start talking about disc degeneration and bulging discs, right, it's nearly 100% of people. So we don't know where to draw the line between the abnormal state and the normal aging, and we typically call it disease when people have pain. But for the most part, MRI is really just used to plan an operation or to rule out really bad things that can either kill or paralyze you. So that's why we don't get MRIs all the time. So the most common pathology that we'll see, or one of the most common things we'll see, are herniated discs. And so the disc itself, again, being the shock absorber, is really made up of two distinct layers. There's an outer ring that we call the annulus, and there's an inner part called the nucleus pulposus. And people like to think of this as a jelly donut, but it's not really a liquid center. It's two distinctly different types of cartilage. This type of cartilage in the center is doing a really good job of attracting water and giving the disc its shock absorbing properties. But as that wears out, two things happen. Number one, the cartilage on the interior degenerates and starts to fragment. And then the outer rim of the disc can actually get a tear. And when you have those two things together, sometimes part of the inner disc finds its way out through the back, and this is what we call a herniated disc. There's really no definition between a true disc herniation and a disc bulge, and a lot of times the terms are used interchangeably. People will also call it a ruptured disc, but when you're talking to a surgeon, the true difference between a herniated disc and a bulging disc is when we say a herniated disc, we mean that there's a nerve that's being compressed by that piece of cartilage. And we don't really know why this happens. We think maybe it's a culmination of aging and degenerative changes. It could be repetitive trauma to the disc. Sometimes these things just happen spontaneously and we don't really have a good explanation for why. But the hallmark of having a herniated disc is severe leg pain. And this occurs in what we call a dermatomal distribution. So when you have a herniated disc, it typically pinches one nerve. And each of the individual nerves in the spine is responsible for providing sensation in a particular area of the leg. So it's very unusual to have a herniated disc and the whole leg hurts all the way around from the hip down to the toes. Typically, we'll see pain on the outer part of the leg or straight down the back of the leg. And that correlates with the two most common nerves that are pinched. And one of the interesting phenomenon is that this can be accompanied with back pain. Or a lot of times it can be preceded by back pain. If you think about the disc wearing out and the disc degenerating, there can be a lot of pain associated with that. But as this center part herniates, it's almost like popping a pimple, and you relieve that pressure in the disc, so people's back pain starts to get a little bit better. But as a result, that pressure that's been released is now this piece of cartilage that's now pushed out and pinching one of the nerves. And then the leg pain starts shortly after the back pain subsides. So again, this dermatomal distribution, this is looking from the front, these left two pictures here. So the L4 nerve kind of wraps around the front of the knee and down the inner half of the leg. L5 will usually come all the way down the side and wrap around towards the top of the foot and the big toe. And the S1 nerve is that classic, I have pain in my butt cheek and it goes straight down the back of my leg to my heel. And so sciatica, again, simply means pain in the leg. It doesn't necessarily mean there's a pinched nerve, although a pinched nerve is the most common form or common reason people develop sciatica. Radiculopathy means that in addition to the pain, you also have some component of dysfunction of that nerve. So either weakness, numbness, changes in the reflex that accompany the pain itself. And this entity of cauda equina syndrome, which is a very, very rare condition, fortunately, is when you have a disc herniation that's so large, it doesn't just compress one nerve, but it compresses all of the nerves in the middle of the tube, and that can lead to loss of bowel or bladder control. That is a true surgical emergency. And if that happens in the setting of leg pain, this is something you should seek emergency care for in the emergency room. So this is a pretty typical representation of an MRI study of what a herniated disc looks like. And you can see the normal discs up here between the bones. They're normally pretty light colored because there's a lot of water. And then this would be a typical degenerative disc between L4 and L5. And the degenerative disc you can see is actually darker because the cartilage is not as good at holding on to water content. And then between L5 and S1, you can see the difference between maybe a bulging disc here and a true disc herniation with a very large fragment protruding backwards. And if you slice the MRI or slice the person like a loaf of bread, this is what you would see. You would see the disc in the front of the spine. You would see the spinal tube and the nerves. The white stuff is the spinal fluid and these little dots are the nerves. And you could see this very large fragment of disc that's compressing the nerves to a great deal. And this would be someone who would have a lot of pain going down their leg. Again, that cadaver study we showed before, this is an abnormal slice. This is exactly what it looks like. A big piece of cartilage is now sitting there pushing on the nerve. Here's the normal side. You could see the nerve is escaping relatively unscathed. And then over here on the other side, the nerve itself is starting to get pinched in that hole. And you could imagine if this is even bigger, it's starting to pinch this other nerve that's coming down as well. So what do we do about this? Well, the good news is even in this situation, most people, 80 to 90% or so, typically have resolution of their pain within the first 6 weeks. So it usually ramps up and gets bad by about week 2, and then from there on out, it will slowly decline. And so initially we just reassure people, get them going with some physical therapy, sometimes some oral steroids, anti-inflammatories, epidural steroid injections. There's a whole host of conservative treatments we can prescribe to help settle things down, and typically the pain resolves. But if it doesn't, that's where someone like me comes in. We're able to remove that piece of herniated disc, which immediately causes significant relief of the leg pain. This is one of the most successful operations in spine surgery. These are typically minimally invasive or mini open procedures. They're usually outpatient surgeries. People go home the same day. Your back is sore for about a week or so, but the leg pain really goes away very, very quickly. And common term for this would be something like a laminotomy or a laminectomy. Sometimes we'll call it a microdiscectomy. But at the end of the day, it's all the same procedure. We're taking the pressure off of the nerve just by removing that piece of herniated disc material. So the real question is, does surgery work? We get a lot of people saying, well, I know my neighbor had an operation. I know 10 people who had back surgery and they're worse than they were before. And University Hospitals was actually a contributing member of one of the pioneering studies in spine surgery called the SPORT trial, SPORT, S-P-O-R-T, and it stood for the Spine Patient Outcomes Research Trial. It was a very large study that encompassed about 12 medical centers across the country. We enrolled thousands of patients combined, and we looked at people who had surgery for a disc herniation versus people who had conservative treatment for a disc herniation. And this is a very busy slide, but if you look over here on the right side, what we're looking at, the diamond markers are the people that did not have surgery, and the little markers here are the people that did have surgery. And if you look at the scale here, this is 96 months after surgery. So this is 8 years out. People 8 years after having surgery have less disability and have less, have better physical functioning scores and better bodily pain scores than those who did not undergo surgery. So surgery does work, and we have very good data that that benefit of surgery is maintained even out to 8 years after the operation. So along the spectrum of lumbar disc herniations is lumbar spinal stenosis. So you can think of the disc herniation as the violent car accident, and you can think of lumbar spinal stenosis as kind of compressing a car or crushing a car in like an automobile crusher, where it's a very long, slow compression of the whole thing. So instead of getting the hallmark of sudden onset, terrible leg pain, lumbar stenosis tends to create a slow squeeze on the nerves. And stenosis just means narrowing. So what causes the narrowing? We'll talk about that in a minute. But the typical symptoms of lumbar stenosis are really leg pain, like with a herniated disc, although it's usually less prominent. Most people develop this insidious pain with standing and walking. It can involve the buttocks, the legs, it can radiate all the way down. Sometimes people will describe it as a sensation of having rubber bands wrapped around their legs or feet, and it worsens with standing and walking. This is something we call neurogenic claudication, meaning the nerves are pinched and it's making it hard to walk. And the typical pattern for this is people have pain and dysfunction when they stand and walk, but if they lean forward, like on a shopping cart or on a walker, or if they stop and sit down, their symptoms typically get better. Now, interestingly, we see a lot of people with hip arthritis too, also with peripheral vascular disease, and those can cause similar symptoms, but a skilled physician can easily kind of tease out the differences by examining someone to determine what the most likely cause of their walking difficulties are. So again, the natural history of lumbar stenosis is a little bit different, right? This is not a one-time event where you have a herniated disc fragment that's pinching the nerve. This is a slow squeeze from arthritic changes in the spinal tube. This is a result of bone spurs forming, bulging discs, ligaments in the spine becoming hypertrophic or abnormally large due to the aging process. And so there's really nothing that can resolve on its own. Every single one of us will have a narrowing of our spinal canal as we age. And at some point, some of us will become symptomatic. So basically, people don't tend to catastrophically worsen because it's a very slow growing problem. But on the other hand, they tend not to get better on their own as time goes on. So if you look at some of the studies on this, one of the earlier studies from the early 90s showed that 32 patients who declined surgery for stenosis who were evaluated 4 years later, the vast majority of them had no change in their symptoms, and only a very small percentage got worse. And this is a typical representation of what an MRI would look like. So it's a little bit different than the prior MRI that we showed. And if you look at this, multiple levels with discs bulging, and you can start to see this thickened tissue in the back of the spine also. This is the thickened ligament that occurs with spinal stenosis. And so looking from the front, again, you don't see a discrete, large, big herniated disc, but you see a bulging disc in the front. The joints here have become large and overgrown. This very thick stripe of black tissue here, that's that ligament. And so what happens is circumferentially from all sides, those nerves start to get pinched and smushed together in the middle of the spinal tube. And when we see that, that can correlate with people having difficulty standing and walking. And again, this is a similar picture looking at the disc bulging, the ligamentum flavum, or the ligament of the spine pushing together, and you could see that nerve starts to get trapped between the disc and the ligament. Additionally, the hole starts to get very small, and this is the nerve root right here. And you can see the bone spurs, or O, that's for osteophyte, bone spurs pushing into the hole, thickened ligament really starts to narrow that hole. So again, what do you do for lumbar stenosis? Well, we try to manage it without surgery. This is not a problem that will paralyze people or put them in a wheelchair, but it is something that can cause a good deal of disability. So we try to modify people's activities. We try to use medications, epidural injections, and try to get them feeling better by treating the symptoms. But if that fails over the course of several months, then surgery is an option. And basically for people with spinal stenosis, it's some type of roto-rooter procedure. And depending on how many levels are involved, we would do a laminectomy or decompression at each of the levels where the nerves are getting pinched. And some people are fortunate, it's just 1 or 2 discs. Some people are less fortunate, and it can involve the entire lumbar spine from L1 all the way down to S1. So this would be a picture beforehand, and this would be a picture afterwards. And you can start to make out the shadow of where all of these spinal nerves, where all this bone was removed and the spinal tube was decompressed. And that's a cartoon representation here of removing that bone from the back and exposing all of the nerves, removing all of the junk more or less that's pinching the nerves and causing the symptoms. So again, surgical results, this pretty much mirrors the same results from the lumbar disc herniation. Same study, the SPORT trial, up to 96 months, so 8-year data that shows people who had surgery are universally doing better at 8 years than people who did not have surgery. One other thing I like to point out to my patients is that we always hold up hip and knee replacements as the gold standard of orthopedic surgery, that people get great results. And the interesting thing is when you compare the benefits of lumbar spine surgery to the same benefits of hip and knee surgery, it turns out that the clinical improvement is the same in both groups, and spine surgery is equally cost effective. Now, spine surgery is a little bit more complicated than hip and knee replacement surgery, so we do tend to have higher rates of reoperations, and that's for a number of different reasons. But at the end of the day, people are doing just as well after their spine surgery as they do after hip and knee replacements. And that's if the surgery is done for the right reasons and the patients understand what symptoms we're trying to alleviate. So another question I get is, do epidural injections help? Again, without getting into too much of the weeds here of the studies, it turns out that when you give people injections of steroids and you give people injections of just local anesthetic, it turns out there's no difference in the two groups. There's no difference in the groups depending on where you give the injection. And it turns out that it might actually make surgical results a little bit less favorable. So I start to question, why are we doing this? It makes sense for a herniated disc where it's a very acute, self-limited inflammatory problem. However, with the lumbar stenosis, where it's a slow squeeze over time, it's not really a big inflammatory problem. So it turns out that the injections don't work as well, specifically for the standing and walking symptoms. So the last thing I wanted to touch on is people that have instability of the spine. And the most common type of instability is called spondylolisthesis. And it literally means spine slip if you translate it from the I believe it's Greek. So basically one of the bones will start to slide forward in relation to the bone below it. So you could see the L4 bone here is not nicely lined up with the L5 bone. It's translated forward by about a third here. It's a condition that's more common in females, but it does affect men and women, and it can affect people of all ages. The symptoms are basically the same as people with spinal stenosis without this slip. Doesn't really predict a worse outcome, but people do tend to have more back pain in addition to the leg pain symptoms when they have the spondylolisthesis present. And again, this would be a typical finding. We'd see that abnormal alignment on an MRI, and we can see a lot of fluid in the joints of the spine, and this is indicative of abnormal motion. So we put these patients into a separate category because spondylolisthesis, or the slip, indicates a degree of spinal instability. And so when you have instability of the spine, the surgical treatment is a little bit different because it does have to include a fusion. And this is oftentimes a difficult pill for people to swallow. Everyone has horror stories about friends, family, neighbors, and members of churches and synagogues who, oh, I know so-and-so had a terrible spine fusion and now they don't walk anymore. And it's a very big misunderstanding in spine surgery. Not all fusions are bad. But the reason we fuse is that people that have a fusion with their decompression in this setting do better than people who have a laminectomy alone. People who have instrumentation or rods and screws have higher fusion rates, and long-term results are better in people that have higher fusion rates. So we deduced through all the studies we have that a laminectomy and fusion for this condition is superior to just a laminectomy or a decompression alone. And surprise, surprise, using the sport trial data, at same data at 96 months, the patients who had surgery are maintaining their benefit out to 8 years out after surgery. So we see the same results following surgery for all types of degenerative spinal conditions. So in conclusion, herniated discs, lumbar stenosis, degenerative spondylolisthesis, these are all very common problems that we encounter with advancing age. The moral of the story is we always use conservative treatment first unless there's a surgical emergency present, and that usually means bowel or bladder symptoms due to cauda equina syndrome. So for the vast, vast majority of people, 99.999% of people, we try something that's not surgery first. And only if the symptoms begin to affect people's day-to-day quality of life do we recommend surgical treatment. It is important to know that there is very strong evidence to support surgery for these conditions, but there has to be a good understanding of what symptoms we are trying to alleviate. We can never make people 100% free of back pain. We can make people a lot better, but we can't turn back the hands of time and make people 20 years old again. So fusion operations also are very successful if they are done for the right reasons. So with that, I'll welcome any questions. I thank you all for taking time, and hopefully this makes sense.
Thank you so much, Dr. Gordon. Just extremely helpful, very valuable information to share. So this is the beginning of our question and answer session. We did have some questions that are coming in, as well as some that were submitted prior to the event. So the first question, Dr. Gordon, is spinal stenosis or scoliosis? Which one causes my poor balance?
Oh boy. So scoliosis means curvature of the spine. And that means curvature of the spine in more than just one plane. We tend to think of scoliosis as the S-shape side to side, but there's also a front to back component of scoliosis, as well as a twisting component of scoliosis. Scoliosis itself is not a painful condition, but it is something that we have to contend with when people develop spinal stenosis or pinched nerves. And that's a 2-hour spine symposium on itself at one of our specialty meetings. So it's very difficult to go through the finer points in a short time. But scoliosis typically does not cause poor balance unless the front to back plane is so out of whack that people are basically falling forward. Lumbar stenosis or spondylolisthesis or pinched nerves in the lower back typically does not cause balance trouble at all. Most balance trouble when it's related to a spinal condition is actually due to a compressed spinal cord. So in the lower back, we're actually dealing with the spinal nerves and not the spinal cord. The spinal cord ends more or less where the thoracic spine ends. So people can have compression very commonly of their spinal cord in their neck. And believe it or not, that typically causes balance trouble way more than lumbar spinal disease does. So one of the common things I'll see in the office is people coming in for lower back pain and leg pain and sciatica. And when we do talk with them and watch them walk, we do find very often that people have very poor balance. And that prompts an evaluation of the neck. And about a third of people who have spinal stenosis or congenital stenosis, meaning born with a small tube in their lumbar spine, have it in their neck as well. So we do see these things go together hand in hand. But one of the big misunderstandings is that lumbar surgery fixes balance problems, and that's almost never the case.
Great, thank you. Next question is a bit lengthy. An MRI showed my pelvis is rotated. Is this likely the cause of lower right back pain? Furthermore,
so I'm gonna stop. Can I stop? Can we take them one at a time?
Absolutely.
so
yeah,
MRIs don't usually show rotation of the pelvis. It probably meant you were just a little crooked in the scanner. So is this the cause of back pain? Probably not. And I'll let you go ahead.
Okay. The remaining part of the question is, the pain does not go below the knee, but I sometimes have what feels like electrical shocks in both feet that only last a few seconds, but is excruciating. It happens when I am sitting. I'm unable to sleep on my left side because of right side pain when I lay on my right side.
So again, not really a lot of a question there. You know, there are a number of things that can cause those symptoms. This is why it's really important, and the work that we're doing together as an institute, myself and my colleagues in orthopedics and neurosurgery and pain management and physical medicine and rehabilitation. This sounds like a perfect person that should be meeting with one of our PM&R or medical spine specialists, because there are so many different things that contribute to leg pain, to back pain, when the symptoms are disjointed and not necessarily a linear relationship from pain that radiates in a continuous line from the back to butt to leg, or that doesn't follow the typical pattern of worse with standing and walking. You know, really like to have people like these symptoms evaluated by someone who could help tease that out and help us determine where the pain is really coming from. So again, without examining somebody, it's almost an impossible question to answer.
Great, thank you. Two-part question. When I sit on a chair for a few minutes and when I get up and start walking, I can't walk straight for 20 seconds. After that, I am normal. So that's the first part. The second part, I can't bend and pick some stuff. I can't bend and pick something from the floor without pain. Is it worth taking SI joint injections if pain is going all the way down my leg?
So again, age of the person asking this question really matters. This SI joint pain, SI joint injections will have no effect on any type of nerve pain. It's normal to have back pain when you bend forward, particularly as you age. You know, again, I can't really answer that question without examining somebody. I know this gets to become a common theme when people ask very specific questions about their own conditions. The issue of not being able to walk straight, I don't know what that means. Is the person lightheaded? Are they having balance trouble? And if it's really a balance trouble problem, do they have other signs or symptoms of spinal cord compression in the neck? That's why it's very important to be evaluated by either a neurologist or a physical medicine and rehab or pain management doctor, or even one of us as a spine surgeon to help tease that out. But it's almost an impossible question to answer without seeing somebody and examining them.
Completely understand. And for those who are still participating, you can find the right provider for the condition and get the answers that you're looking for by calling 216-714-8118. That is the main line to the UH Spine Institute, and they will get you to the right provider. Next question, would dry needling help the pins and needles feeling I experience in my right foot due to spinal stenosis? I have no pain in back or leg.
So Again, the pins and needles sensation, if it's isolated just to the foot, it's very difficult to know, is it truly coming from spinal stenosis, or if there's another source for neuropathy in the feet. Diabetics commonly develop neuropathy or pins and needles sensation in the feet. Can happen in non-diabetics as well. Sometimes we need to do special nerve tests called electromyography or EMG and nerve conduction studies to help determine what the source of that pain is. Typically speaking, dry needling is a technique that's used to help with muscular pain, not so much with neurologic dysfunction. And truthfully, there's not any good evidence to support using dry needling for anything. But on the other hand, there's very little evidence to say that it harms anything. So I usually tell people in these situations where there's a relatively harmless treatment that doesn't have any good data that it actually works, that it's worth trying once or twice. The worst thing that happens is you don't notice a huge difference, but I don't advise people typically to spend their hard-earned money and their time on treatments that aren't proven to work.
Thank you. Next question. Advice for a 28-year-old with severe stenosis and spondylolisthesis who has had little relief with meds, physical therapy, and injections. Daily pain down my legs when walking and standing. I'm very scared of fusion, which has been discussed with me since I'm so young, having read about repeat surgery with fusions.
Yeah, so one of the most widely known phenomenon after fusion surgery is people worry about what happens to the disc above your fusion. There's a 1 in 5 chance that over the following 10 years, so within 10 years of the first procedure, that a fusion operation will be necessary at the disc above. Now that's due to a number of different factors, and we're getting better at understanding why that happens. So we know that if we get the alignment of the spine into a better position, that we can reduce that risk tenfold. We can't make it 0 because the rest of the spine is still going to age. Now, that being said, you know, at the age of 28, if you're already having that type of miserable pain, can you make it another 60 years or so with that type of pain? Because at some point it's going to get the best of you. And if the x-rays and MRI do in fact match and show stenosis that is consistent with the area where you're having pain, you know, then we can tell you there's an 85% success rate with surgical treatment in terms of improving leg pain and standing and walking endurance. And, you know, only you can decide, you know, whether or not you can tolerate the symptoms any longer. So, you know, age certainly plays into it, but it sounds like this individual has completely exhausted non-surgical treatment. So you get to the point where it's time to, you know, I guess, make a decision and stick with it.
Thank you. Next question. I have pain usually at night, straight down the side of my leg that goes at least to my knee while I'm laying down. Terrible pain, feeling almost like a cramp. Any ideas who I should see or what I need to do?
You should call 216-714-8118, and we would be happy to see you in the office. Now, if you've had a recent MRI study that was either done through university hospitals or somewhere else in the last 2 years that you could bring on the disc, our schedulers will be happy to make an appointment for you with either myself or one of my surgical colleagues. But if we haven't had any type of workup or treatment for this problem yet, we usually get people like this in right away with one of our medical spine providers to really start treating the problem under the assumption that it certainly sounds like spinal stenosis. Again, most people won't ever come to needing an MRI the first time they see us, and we usually are pretty successful at treating the pain initially with a host of treatments, including medications, therapy, and possibly injections.
Thank you. Next question. I've had epidurals for perhaps 15 years, generally once a year, but now I've had epidurals 2 months apart and there is no relief of my pain. Is this a reason to talk to a surgeon?
Yes. Again, not specific where the pain is. Are we talking just pain in the back? When does the pain come on? Is there leg pain? Is there numbness? Assuming we're talking about leg pain and difficulty with standing and walking, you know, having decreased effectiveness of injections over time is a very common problem, and that's typically when people decide that it's time to at least consider surgery.
Thank you. So in terms of treatments for sciatica and degenerative disc issues, What about physical therapy? Is that something that I can look at for treatment?
Absolutely. I mean, we always start with physical therapy. Physical therapists are excellent at developing a personalized program to help stretch and strengthen the core, sometimes providing some manual traction, and just supporting the muscles and doing some other treatments in terms of heat or ultrasound or TENS that can really help decrease the feedback of pain. So, nobody aside from a surgeon can actually take care of the underlying problem in terms of reversing the pressure on the nerve. But very often people don't need that problem resolved because it's been there for a long time before the symptoms come on. So we're usually able to treat the symptoms first, and physical therapy is always the first place we start. And in fact, most insurance companies, actually all insurance companies, require that you do at least some physical therapy before either they even approve an MRI, and certainly before they approve any surgical treatments. So a responsible surgeon would certainly recommend that, and most of our, I have to say, all of us do routinely.
Thank you. Next question. Hello, Dr. Gordon. I am on blood thinners due to a history of DVT. Since I cannot take anti-inflammatory drugs, what type of pain meds would be best for me? And would a steroid shot be something I would be able to have while on my blood thinners?
So you can't have any type of spinal procedure, injection, surgery, or otherwise while you're on the blood thinners. And again, without knowing the specifics of the underlying medical condition, most people are able to stop their blood thinners temporarily for a procedure, including spine surgery. The risk you take is really dependent on how bad your symptoms are. So if someone had tried just a little bit of annoying leg pain, they probably wouldn't want to take a risk of having a blood clot again, or a pulmonary embolism that could cause death, frankly, to take care of a minor annoyance. But I do have a number of patients who've had history of blood clots for genetic reasons, for reasons that we don't understand, and the vast majority do fine without any recurrent clots. But there is an elevated risk to operating on people like that. We do have to put them on blood thinners after surgery, and that can cause a certain risk of certain complications to go up a little bit. But injections would be a reasonable thing to start with, certainly before surgery, because the risk of bleeding after injections is much lower than the risk of bleeding after a surgical procedure.
Thank you. Next question, and this person says, unfortunately, they're a mess. I have fusion L3, L4, L5 from a 2003 laminectomy. In 2012, they had to shave off L2. Now I can only walk about 30 steps, and then my legs begin to give out with pain and lower back cramps. Bending to touch toes gives relief, but I can't walk like that. What next? I have rheumatoid arthritis, and the neck has disc out, as does thoracic.
So first of all, that's an interesting point, because thoracic disc herniations are almost never a problem. If there's severe spinal cord compression from a thoracic disc herniation, that is an exceptionally rare situation where it can cause really profound trouble with walking. I would say that as a busy spine surgeon, I treat maybe 1 or 2 people a year for true thoracic stenosis from degenerative conditions. Now, we specialize at university hospitals, especially at the main campus and the practices that we typically see, taking care of very medically complex patients. And it doesn't mean just because you're a quote unquote mess, and I'm sure I've seen people who are worse off, that surgery is not necessarily off the table completely. It's a conversation that you have to have, with a surgeon. It certainly sounds like the symptoms are consistent with spinal stenosis. What do you do about it? We're happy to provide consultations. And basically at the end of the day, I tell my patients, listen, here's what it would take to correct your problem. Here are all the problems that you have that are going to either make it easy, hard, or impossible for you to recover from this surgery. And if we get into a situation where the surgery is very large, but my patients understand that, well, I don't really have any other choice, and I'm willing to accept the risks that come with it, we don't necessarily withhold treatment unless things are so extensive that we know for a fact that we're going to cause harm and have very little results in terms of success. So again, the interesting thing about spine is there's not a one-size-fits-all solution for people, and these are really long conversations, usually over multiple visits that have to be had between a surgeon and their patient.
Thank you. Next question. I've had pain in my backside for years. It is a daily thing, which I feel now 24/7. Have I waited too long to get this looked at?
No. But most people who have daily back pain, chronic back pain, the number one reason for just having to get out of control is really just failure to get adequate treatment to begin with. It might take a little bit longer to get it under control. It almost seems like it becomes an insurmountable task in order to do certain things when you're having chronic daily pain. But being evaluated by one of our specialists is obviously the best way to go. And as long as there are no red flag symptoms, the typical things we recommend are therapy, medications, aerobic exercise, core strengthening. Usually takes a number of different treatments all at once for a sustained period of time. But we are able to have good results, even for people who have had chronic back pain that feel like they let it go for too long. But there really is no such thing as too long.
Thank you. Next question. I just finished physical therapy. My pain starts in my buttocks and goes down my leg to my foot, making it very painful to drive. I've already had an epidural. Will a cortisone injection help or could it hurt?
So an epidural and a cortisone injection are more or less the same thing. Again, it's very difficult. A lot of times people don't know specifically what kind of injection they had. So if you already had an epidural and it didn't help at all, or it only helped for a very brief period of time, a second epidural almost never helps. And this would be the type of situation where you have to say, all right, I'm going to live with the symptoms as they are, or we're going to look into fixing it.
Great, thank you. This is a quite lengthy question, so if at any point you need to stop me, please do so to provide an answer. I am 57 years old and have had severe spinal stenosis and degenerative disc disease in my lumbar and cervical spine for many years. I had a laminectomy at L4 30 years ago. I have had numerous epidural injections over the years for temporary relief. I have had all of the sciatica symptoms over the years down the leg and into the foot. Now, I have severe pain down the front of my left thigh, which I have never had before. My thigh is getting weak. At the same time, I have lower back pain, which I have lower back pain now, which is rare. Could this be coming from my hip, or does it sound more like spinal stenosis acting up?
So it's a very detailed history, which is really good to know. So groin and thigh pain can be referred from the back. It can be coming from the hip. And the only way to tell realistically is to examine somebody and check x-rays. So the answer is yes, it could be coming from your back. Yes, it could be coming from your hip. It sounds like there's a problem with spinal stenosis. So at least some of this is spine related. But seeing one of us to help determine that would be the best course of action.
Great, thank you. Next question. Most times I have stiffness in my back rather than pain. My PCP says it's arthritis of the spine. Does arthritis cause stiffness?
Yes. But so the short answer is yes, it causes stiffness. But like with any type of degenerative condition, the most important thing to do is use what you have, or you're going to lose even more. And so really aerobic exercise is key to maintaining a healthy back. It's key to helping treat back pain. We know people that get 2 to 3 days a week of aerobic exercise. And what we mean by that is low impact cardio. So walking, bicycling, elliptical, swimming, something to that effect. If you do that for 20 to 30 minutes a day, 3 times a week, you'll have much less back pain, much less stiffness. And when you do get back pain, it's much less severe than people who don't get regular aerobic exercise.
Thank you. Next question. I am currently in therapy and am on the DRX for 28 minutes. I have been there for 10 visits and I feel good after treatment, but get a lot of pain from sitting or standing for long periods. The pain goes from my lower back to my foot. I lay on the floor at home for an hour or more at night and that helps. When I get up in the morning, I feel good. After sitting, it progressively gets worse. And it's basically just a statement, not a question.
Okay, so again, this could be typical of a herniated disc, of spinal stenosis, of just the type of discogenic or disc-related back pain with associated nerve irritation without necessarily compression. Again, the only way to know is if you've been doing therapy for that long is to get an MRI and then be evaluated by a surgeon who can look at the MRI and tell you whether or not the symptoms you're having match with the MRI you have and whether or not reversing those changes on the MRI can make a difference in your life. So, the important thing is always trying conservative treatment first, and it sounds like this person has certainly been doing that. They respond well to therapy initially, but then things tend to settle out as time goes on.
Thank you. Next question. I've been dealing with sciatic pain for a while. Should I visit a spine specialist or a chiropractor first?
You should call 216-714-8118. Really, and I say that kind of half jokingly. If you're having neurologic symptoms, there's really no evidence to suggest that chiropractors can cure neurologic symptoms with manipulation of the spine, number one. Number two, we don't know what's causing that problem. So if you're having just lower back pain without neurologic symptoms, absolutely see a chiropractor, see a therapist, see a massage therapist, whatever feels good. But when there's neurologic symptoms present, it's almost always best to be seen by a physician first. And that can be either a medical spine provider, a physical medicine and rehab, or physiatrist, a pain management specialist. Again, someone who could help get imaging and start to treat the problem alongside of determining what the underlying cause of the leg pain is.
Great. Well, I think you may have already answered this, but I'll share it with you anyways. Is there research on chiropractic treatment for these conditions, specifically for a slipped disc?
Yeah, so slip disc, if you're referring to spondylolisthesis, the answer is not really. So the interesting thing about chiropractic care and research is, what do you compare it to? So there's really not a lot of good comparative studies of anything, including physical therapy and a lot of other medications. But when we talk about injections, right, so you can inject somebody with a steroid, or you can inject somebody with another medication that's not a steroid, and they and the doctor don't know. So that's what we call a double-blinded study. And I'm sure we've all heard a lot about randomized double-blind trials in the current climate with coronavirus. And those are really the gold standard for helping to determine a difference. The problem with chiropractic manipulation is it's really hard to develop a sham treatment, if you will, to compare it to. So that, if you're doing something to somebody, regardless of whether or not it works, there is a significant placebo effect. And so people want to believe that what they're doing is working. And we also have studies that tell us the more you spend on something, the larger the placebo effect is. So a lot of times people have significant out-of-pocket costs. So the short answer is no, there's not a lot of good evidence for chiropractic care. The longer answer is there's really not a lot of great evidence for a lot of the things we do, with the exception of physical therapy and medications. And even the evidence for those types of treatments are fairly weak if you hold it up to rigorous criteria. So I don't want to bash chiropractors. We have chiropractors employed through university hospitals. The most important thing is when you go see somebody, chiropractor or otherwise, that they're acting reasonably. If somebody tries to sell you a bill of goods, if it sounds too good to be true, it probably is. And if someone tries to scare the living daylights out of you and tries to talk you into signing up for an expensive treatment, get a second opinion.
Thank you. Next question. What is DISH disease? D-I-S-H.
So DISH stands for diffuse idiopathic skeletal hyperostosis. And this kind of runs hand in hand with another condition called ankylosing spondylitis. Basically, these are types of inflammatory conditions, and one of the symptoms of these conditions is that the spine tries to fuse itself together. And that can be a painful condition because it's basically like having a 10-level fusion from a surgeon, but your body's doing it to itself spontaneously. So it can cause stiffness and pain. More importantly, what we see, those people that have a true DISH spine or ankylosed spine are very high risk for having fractures if they fall or experience a trauma. And oftentimes those types of fractures can be very unstable and cause neurologic injury. So it's important to know if you have it, if you have DISH or ankylosing spondylitis and you suffer even what seems like a trivial fall, that you get it checked out right away.
Thank you. Again, this is a bit lengthy, but if you have to stop me, just please let me know.
Okay.
I had a lumbar MRI about 15 years ago that showed spinal stenosis, bulging disc, and arthritis. However, at the same time, I was diagnosed with MS, and I have a lesion in the thoracic area of my spine. At that time, I had no back pain, and these problems were never addressed. Over the last few years, I have been experiencing more loss of balance, increased numbness in my right leg, increased loss of urinary control. My question is, how do I separate what is being caused by my MS and what is being caused by the problems in my back? I'm currently 57 years old. Also, a more current MRI shows disc disease in the thoracic area of my spine. What type of doctor should I start with? I currently see someone for my MS.
Yeah, so again, thoracic spine stuff is really not much to be worried about. It's very rare to have compression of the spinal cord in the thoracic spine from normal disc degeneration. A lot of times symptoms of multiple sclerosis overlap with spinal stenosis, but a lot of times people blame the MS for everything when there's a problem that is potentially reversible. So I always have people see their neurologist first just to assess their overall status with their MS. And I'll be very honest, I'm very bad at telling you, what the symptoms are or what you should expect in terms of multiple sclerosis. But we do see people with MS that unfortunately are not immune from having other conditions of the spine that can cause dysfunction. So, always starting with your established neurologist is usually the best course of action, making sure that we have updated MRI studies. And then if the MRIs are there, then seeing a spine surgeon can often help determine whether or not some of the symptoms or all or none are coming from the pressure on the spinal cord or nerves. At the end of the day, multiple sclerosis is not a reversible problem. And some of these spinal compression problems are reversible. And depending on the timing and the progression and the symptoms, I have a lot of people say, well, let's just fix the stuff that is reversible and we'll see what happens. So, there's less good data on patients with MS and spinal stenosis, but if the symptoms match, we usually expect to see good surgical results.
Okay, and this is going to be our last question as we are almost out of time. The question is the rotor-rooter surgery an outpatient procedure, or do you need to stay in the hospital?
So the answer to that question is it depends. It depends on how healthy the individual is, what other medical conditions are present. But more often than not, it depends on how many spinal segments are involved. So a rule of thumb for a one-level procedure, whether or not it's a disc herniation at one level or spinal stenosis at one level, as long as it doesn't require a fusion, if it's just the roto-rooter procedure, single-level surgeries are often done as outpatient surgeries. When you get to the 2 levels, it can be either or, depending on the individual. But usually 2 levels or more, we tend to put a drain in and keep people in the hospital overnight for one night. The interesting thing about single level fusions, when they're done in a minimally invasive fashion, the vast majority of those patients are going home within 24 hours also. So it all depends on the underlying problem, how many levels are involved, and whether or not the treatment is maximally invasive or minimally invasive.
Well, thank you, Dr. Corden. We really appreciate you sharing your time, providing this information and answering all these great questions that we received. A couple of reminders for the audience. Again, this presentation was taped. You will be receiving an email within a week to 2 weeks with a link to this session for you to view if you choose to do so again. And it will also be placed on the University Hospital's website, uhhospitals.org. To schedule an appointment with Dr. Gordon, call 216-714-8118. We have multiple access points all over Northeast Ohio, so I can almost assure you that we have a location that will be conveniently located close to your home. You can also visit uhhospitals.org/spine. This concludes this evening's event. Again, on behalf of the entire University Hospitals family, thank you for attending, and we hope you'll join us for future webinars. Have a wonderful evening.